me start by thanking the organizers, thanking Mary and Julia for organizing this amazing conference, inviting all of us. It's a great privilege to be here, and I'm really proud of it. And I must say I'm proud of another thing as well. I was looking at the list of speakers today, and I saw that 4 of my former PhD students are giving lectures today. So we are really groin and hip nerds. I'm an orthopedic surgeon in a public hospital. I have no financial disclosures. I've been interested in groin problems for 30 years on a non-surgical basis mostly. And the last 10, 15 years, I started to do some hip arthroscopies, and now this is my main surgical area. So I treat hip problems, both surgically and non-surgically as well. So just so you know who you've got in front of you. Groin problems, well, that's a major problem in the football codes, and especially in real football, as the Americans call soccer. In a cohort of 700 Danish sub-elite football players, we found that nearly 50% had experienced groin problems in the previous season, and 1/3 of those had lasted longer than 6 weeks. And there was a trend that they actually carried this problem over to the next season. So there's no doubt this is a huge problem. And when we talk about groin problems, we traditionally talk about the groin area and the muscles and tendons in that area. And that is the adductor muscles, especially adductor longus. It's the hip flexors, especially psoas, but also rectus femoris. And then maybe also the abdominal muscles when we're talking about the inguinal part of groin problems. But we should remember that the hip joint is actually situated right there in the groin. So the hip joint pain is groin pain. It's not hip pain. We've said hip pain quite a few times today. We said hip-related pain, but we don't know if it's actually anything to do with the hip. It's groin pain. And then the hip joint can be part of one of the causes for groin pain. So it's important to have that in mind all day long. So these 2 guys sitting up there is Per Renström and Lars Pedersen. They are pioneers in this field as Swedish orthopedic surgeons, very interested in football and groin problems. And in 1980, they published a very classical paper in PGSM looking at a group of athletes with groin problems that they followed, and they divided them after the anatomy. And they found that 62% had groin problems related to the adductors. And as you can see here from the Uefa Champions League studies done in 2009 and later on in 2018 from Jan Ekström's group and published by Werner, it's also adductor problems. It's 2/3 that are adductor problems, and then some iliopsoas, some inguinal, and 4 to 5% hip related. And as we also heard before lunch by Joe Kemp and others, that well, this is an athlete's problem, but it's also not an athlete's problem. And maybe not so much a huge problem when we talk groin injuries in elite athletes or actually also sub-elite athletes. But it's there, and we need to find them, because otherwise they'll be in trouble. One thing that I think is very interesting with these papers is that 14% of all time loss injuries in the UEFA Champions League study is groin injuries. So it's a serious, really serious problem, both to the players and the clubs. We did a study on non-elite Danish football players, following them, 1,000 players, following them for a year, and we found a similar pattern. And recently, Andreas Sörner, whom you're going to listen to later this afternoon, did his PhD in Doha in Qatar and looked at acute groin injuries in that context. And he looked at 110 acute injuries and found also 2/3 were adductor related. Also a lot of iliopsoas and rectus femoris, some abdominal injuries as well. He also did a systematic review, found that in 72 studies, 33 different diagnoses were used on this. So it was like osteitis pubis, something that should have been left many years ago, core muscle injury, whatever that is, athletic pubalgia, athletic shoulder algia, athletic knee algia. I mean, yeah, it means you have pain in the pubic region. Athletic groin pain in athletes, and then pubic aponeurosis injury, a diagnosis I'll come back to, which has absolutely no sense. The Doha Agreement paper that was published in BJSM in 2015 was an attempt to change that. And we ended up defining some entities. We're not defining the diagnosis, we're not there yet, but we're defining entities: adductor-related, iliopsoas-related, inguinal-related, and pubic groin pain. We also talked about the hip-related groin pain, but at that stage, we didn't go there, and there's been more consensus, and we're going to have more consensus, so we're going to develop on that as well. So, anatomy, to me, is the key to solve these problems. Anatomy, of course, is the basis of biomechanics. It's the basis of the core. It's the basis of the synergies between all the muscle groups. But we need to look at the anatomy, and I think this is a good way to understand what is happening. Take a look at this. This is a study, American study, that has seduced a lot of us. Pubic aponeurosis injury. A lot of you have probably read studies and heard lectures talking about some aponeurosis pubic thing in front of the symphysis joint, pubic bones, like something floating around there where the adductors are inserting and they're going directly into each other. They're going into the rectus abdominis, and everything is connected. And this came from these studies where they said, well, there's a defect here in front of the pubic bone because the rectus abdominis is going down here. It's connected to the adductor longus and going right into that muscle. So muscle is going into one muscle, it's going into the other. And then this is the lesion. But if you look at the MRI that they used, this is the rectus abdominis, and it's actually inserting here on top of the pubic bone, as you can see over here. And in front of it, you have the pyramidalis muscle. Do you remember the pyramidalis muscle? I didn't when I heard of it first here in this context, but it's actually a small triangular muscle that's situated in front of the pubic bone, in front of the rectus abdominis, and it's the muscle going down here in front. And this is lateral to the midline, so what they're seeing here is an adductor lesion. So this context that the rectus abdominis is going all the way down here, it's not, it's stopping up here, so this is wrong. And it's not in connection, direct connection with the adductor longus. Take a look at these beautiful dissections made by Ernst Schilders and Shino Baram. We published that last year in Kesta. Really, really nice study that I can recommend you took a look at to understand the anatomy. So here you have the pyramidalis muscle, this triangular muscle on each side of the midline. Here you have the symphysis joint, here you have the adductor longus, and up here you have the rectus abdominis muscle. So when we flip down the pyramidalis muscle here, and then we look up here, and then we have the rectus abdominis sitting here on top of the pubic bone. Here starts the symphysis joint, going down here. The adductor longus is down here. And then this is the final proof that tendons are not working from a pubic plate fascial thing in front of the pubic bone, but it's tendons inserting into bone, and they're pulling on the bone. Every muscle is pulling on a bone. So this is the way muscles work. Oops, sorry. Yeah. And here you have rectus abdominis on top of the pubic bone. Here we took off the pyramidalis, and this is the pubic crest. The pubic crest is this area. So this is where the pyramidalis is sitting. And down here is the adductor longus sitting down here in this area. So it's rectus abdominis, pyramidalis, and this adductor longus. They are individual insertions into the bone, and this is how they work. They have connections, fascial connections that we might not understand yet, but the main thing, the main way they're working is this way. So to examine all these muscles, you need reproducible tests. And there's a number of reproducible tests out there that you can take a look at. This is a squeeze test. There's lots of squeeze tests you can do for the adductors. This is the one I've been sort of working with and felt for many years. That was the one that worked best for me when I tried to diagnose athletes with adductor-related problems. And I was very happy to see that two studies from Australia, one by Greg Lovell and an EMG study, and one by Mick Drew, who we heard earlier today, an experimental pain study, showed that doing it in this position is the best way to identify pain related to the adductor longus. And since we know that adductor longus is far the most injured muscle, and it's 2/3 of the groin injuries, I don't know why the Australians insist to make squeeze tests with flexed hip and knee. But yeah, well, we can discuss that later maybe. After all, they're the ones who proved that it's actually the best way to do it in extended position. When you do this test, the patient will have, if they have this problem, pain at the insertion of the adductors at the pubic bone. And this is where you go for the palpation as well. So you have to go find the tendon, follow the tendon, and in the long-standing patients, the pain is at the insertion. In the acute patients, it can be at the tendon, muscular tendinous origin, down in the muscle, but that's another thing. I'm talking about the long-standing patients here. If I test the psoas, I prefer to do it in this position, 80-90 degrees of hip flexion, to take as much as possible away from the TFL and the rectus femoris, to isolate the iliopsoas muscle as much as possible, to test for strength and also pain in this position. I used to do a lot of Thomas test. I don't do a lot of it anymore, but I still use it, especially in differential diagnosis, to see if they are very tight and if they have pain that reproduces that pain when I do a passive stretch. But this is the most important test for the psoas, the palpation. And you can palpate the psoas in two sides. You can do it either abdominally or you can do it under the inguinal ligament. If you do it abdominally, you do it at the level of the anterior iliac spine, just lateral to the rectus abdominis. You have to get the patient to relax, put your fingers down there, don't put any nails in, get him to relax. Then he lifts one leg, and then you can feel the muscle under your fingers, you can slide the skin, and you can palpate. Usually, it's in the distal end of it, it's down towards the tendon that they have the pain. And the side where I find most of the patients have pain and say, yeah, this is the pain, this exactly, that's where it is. That's actually here under the inguinal ligament. Just medial to the sartorius, lateral to the vessels, just up under the ligament. In that triangle, that's the only side where you can palpate the iliopsoas subcutaneously. It's right there under your fingers. Get the patient, find the place, get the patient to lift the leg a couple of times, adjust your position, and then palpate. This psoas muscle, I've been fascinated by a psoas muscle for many, many years, and I still can't really figure it out, but it's an amazing muscle. It's a big muscle. It's got a lot of insertions proximally, and we usually say they come from there and then they insert at the femur. Probably it's the other way around. It comes from the femur and then it sort of supports the trunk and the pelvis, and I think that's much more important actually than the flexion, hip flexion, but actually it might be 50-50, I don't know. But it's also a stabilizer of the hip joint to some degree, coming in front here, and we know from arthroscopy, the early days where quite a few psoas releases were done endoscopically, and there was some cases of people who got dislocation of the hip joint afterwards. So don't take too much of the psoas if you do it. So it is an important muscle in that context. But also remember that when you are doing the impingement test, flexion, adduction, and internal rotation, you are squeezing this psoas as much as you're squeezing the hip joint. So a sore psoas, a painful psoas, will give you a positive failure test. And also, this muscle has some implications because for the joint, because it's there in front as a stabilizer, but also as a muscle that might irritate and might even give rise to injuries. This says it's because it's a tight psoas tendon. I'm not sure that's correct. It might be also that it's a weak muscle that cannot control the tendon, and then the tendon is going walkabout and doing strange things here in front. But this is on the outside of the capsule. The joint is, of course, on the inside, and you can see tears and lesions to the labrum, probably made by the iliopsoas. You can also palpate on the lower abdomen if you are looking for patients with inguinal-related, abdominal-related problems. If you go for the conjoint tendon, that's the transverse abdominis and external oblique tendon going down to the pubic tubercle, just lateral to the inguinal ligament. This is a place where a lot of patients with inguinal-related is what encompasses also what some call sports hernias. They are very often sore there at the pubic tubercle. You can also go on the midline, and remember the rectus abdominis is not going in front, it's just ending up there on top of the pubic bone. So you palpate on the top of the pubic bone on each side of the symphysis joint. And if you want to palpate the inguinal canal, I recommend, because this is subtle changes you're looking for, get the patient standing, invaginate scrotal skin, and then put your finger up into the inguinal canal. You'll find that the patients often, well, start on the good side. Some of us in here know it's quite uncomfortable. So you start on the good side and then on the other side, and then you palpate, find the ring, palpate the ring, and push posterior lateral. This is where you find the posterior wall, and this is where, if this is a problem for the patient, they often say, this is the pain I feel. This is the pain I know. And that's a very important thing for you as a physician or a physiotherapist. Then just the last thing about diagnosis, the greater trochanter pain syndrome. When I saw that come up, I got pale and had to sit down for a while and have a beer. And I thought, well, now we're traveling 30 years back in time. Why are we suddenly coining something called greater trochanter pain syndrome? One thing that definitely is not sore is the trochanter. The bone is not sore. It has nothing to do with that. It's in the region. So now we're putting a syndrome on a region with muscles, bursae, tendons, joints that actually are quite easy to test. And then we're just putting it all in one big garbage can, and then we are tempting people with shock wave, laser, ultrasound, and strange stuff, PRP, to do stuff in that region, instead of making a proper diagnosis and treating the injured structures. So anatomy is the key. Look for the structures that are injured and examine them properly. I think that's a good way to go. So how about treatment? We did a study many years ago in the 90s looking at long-standing adductor-related problems. It was patients who had really long-standing problems, close to 1 year. 2/3 of them had stopped doing sports because of this. And in those days, and you have to believe me, most of you were not physios in those days, but in those days they were treating patients with massage, transverse friction massage, laser, ultrasound, and stretching, and no exercises. So this was the physiotherapy group. Later on I changed it because a lot of physios got quite angry with me, so I said, no, it's not a physiotherapy, it just means passive therapy instead. So, and this was the active therapy. And this, luckily, has become real physiotherapy today. But in those days, it wasn't. So we compared these two in a randomized trial, and as you all will know, it ended up showing that the active treatment was excellent and worked much better. We started out with isometric exercises, squeeze exercises, balance, coordination, going into more and more dynamic exercises, strengthening exercises, and demanding coordination exercises. We did a follow-up 10 years after and found that the group that did the active treatment was still significantly better than the other group. Important aspects of the program is lots of repetitions. You do it 3 times a week. It takes quite a long time to do it, but you have to invest. This is something that has been going on for a long time. No pain-provoking activities running after 6 weeks if there's no pain, and good results can be achieved in our study in 4 months. And I would say in athletes, elite athletes, our experience is that you can do it faster, and this is, as we all know, when you do it by the book in an RCT. If you look at this app, as mentioned down here, that is an app to a video that was created by a Dutch physiotherapist, Roald Otten, that I worked with in Doha. And he did a video of all the exercises, so if you take that app, you can go in and see exactly how the exercises are done. Adductor tenotomy is something that has been used and maybe sometimes still used. I looked at it. I did something unusual. I did an unsystematic review. Usually for every RCT we have 10 systematic reviews. But this time there was no RCTs, so I did an unsystematic review. I looked at 5 level 4 studies, great variety in study design, and found that they had excellent results in between 50 and 75%. Poor results in up to 17%, and complications in up to 1/3 of the patients. The active exercise program had excellent results in 79%, poor in 3, and no complications. So if you're working with long-standing adductor patients, it might be worthwhile to take a look at this app and the program. Looking at inguinal-related problems, we have no evidence-based non-surgical treatment programs, unfortunately. That's embarrassing, but we still haven't. What I usually do is use the general principles of strengthening the muscles, training balance, coordination around the pelvis, the way we do it in the adductor program. And then I add particular focus on specific abdominal muscle exercises, like exercises from extension, like when you are playing football, you're not using it so much in the crunch, you're using it from out there. And if the exercise program is not sufficient, then surgery can be an option. The basic principles for this surgery are similar to the treatment of hernias. Open, can be endoscopic, and there's no hernia sac to invert or remove. Unfortunately, I have to say the same goes for your psoas-related groin pain. We have no evidence-based rehabilitation programs yet. Hopefully we'll get there soon. Again, use the pelvic training, strengthening, balance, coordination, and then a particular focus on specific exercises for the hip flexor muscle. Start with isometric, start with gentle eccentric exercises, and then continue with heavy, slow resistance training. We did, for instance, an RCT using a simple psoas exercise like this with a rubber band with young footballers, and found a 17% increase in just 6 weeks. If it's too painful to do the strength training program, ultrasound-guided cortisone injection can be done. As you can see here, this is the femoral neck, lesser trochanter, and this is the psoas tendon. And then we put in the needle here, and we can make an injection quite controlled around the tendon. This is not treating the patient, but it's taking down some of the pain and making it possible for those who have too much pain to do proper exercises. So we'll help them in that way. Return to play in 3 to 6 weeks, and I would say in athletes, never, almost never, I have to say almost, but almost never indication to do iliopsoas tenotomies partial or whatever. How do we monitor these patients? Well, we heard a bit about IHOD, a little bit about Hager's. Hager's is the only one with subscales. Sometimes you use subscales in IHOD, but it's defined as a one figure. But here we have 6 subscales: pain, symptoms, activities of daily living, sport and recreation, physical activity, and quality of life. It's been translated into several languages, and it's shown its value in many studies, both on hip surgery and on groin treatment. And this is the only PROM that is designed for both the soft tissue problems, the groin problems, classical groin problems, and also for hip arthroscopy patients. So I would recommend you take a look at this one. It works very well, and it's been very helpful for us in our treatment and also in our research. Then we heard about this by a couple of the speakers. Mike did a very nice presentation on it as well. I'll just make one comment on it, say that it's a triad of symptoms, clinical signs, and imaging findings. And as I see it, the imaging is unfortunately still the one who decides. Because if you took imaging away here, the symptoms and the clinical signs would be any kind of groin patient. And then we say, well, we're not looking at the imaging because the imaging is not going to decide what we're doing. But at the end of the day, the 2 other groups, they look like all groin patients. So we need the imaging to put them in there. So we still don't know whether a patient with femoroacetabular impingement syndrome actually has hip-related pain, if they actually have hip pain. We need some tests to define whether they have hip pain or not. I know Mike mentioned it, and I know that Mike Ryman is very positive towards injections, not cortisone injections, but local anesthetic injections into the joint to see if the hip joint is actually painful or not. So that might be something, and that's what we're using in our daily practice in the hospital in Copenhagen. So be careful when you talk about hip pain and hip-related pain. We don't know if it's hip. We just take a groin injury, and then we look at some x-rays and say, now it's a hip injury. I'm not sure that's correct to do. Anyway, the impingement test. We all know that one: flexion, adduction, internal rotation, high sensitivity, low specificity. Remember that, and remember that if failure is not positive, then I would say in my practice that then it's unlikely that we have a hip joint problem. Never say never. That's the way it is in our business. But I would say that if the failure, no matter how much I push and turn and twist and so on, and they say no pain in the groin. They have pain lots of other places. Oh yeah, it hurts because you're stretching my buttocks now, or you're stretching my whatever. So it has to be groin pain and the pain that they know deep in the groin. We had this trial. Came out this year, published in The Lancet. They say they have 1 year after randomization. It's important to realize that it's, for some of the patients, only 6 months after they started treatment, because there's a long waiting list. So this is a very pragmatic study. So we only have, I'm really looking forward to see the long-term results. But my gut feeling with this study, and being a surgeon and having worked with this for 10, 15 years, is that they will probably have long-term effect, also positive for the surgical side. It's not a big difference. And I think that's very important to realize, that physical therapy is in many cases equally good. And what we need to do is to find the patients who need surgery or who do not need surgery, or I would say who needs physiotherapy. They all need physiotherapy, also those that we do surgery to. But some of them can do with physiotherapy, and that's enough. But that's the big thing. And we shouldn't go on doing physiotherapy for a year with a patient who's got a structural injury in the joint that we just make worse and worse and worse. On the other hand, we should definitely not do surgery to a lot of patients who actually have no hip joint problem, but have muscular problems around the hip joint instead, or have a minor joint problem that we actually can solve with better physiotherapy. So I think that's the point. It's not pro-physio or pro-surgery. We are working together on this, and I think this is extremely important also for future research, that we look at it in that way. Return to sport. 2 excellent studies came out this year, one from Sweden and one from our group in Denmark, where Lars Ishøj did an excellent study on our registered patients. And it was also mentioned earlier that 70 to nearly 90% returned to sport, but only around 15 to 20% to the same sport as before injury with optimal performance. And is that because surgery is not good? Is that because we're not doing a good job when we're in there? I don't think so. I think these patients have been, as we have heard a couple of times, 1 year, 2 year, 3 year before they came to the surgery. Then we did some surgery, and in most cases, I think the repair is okay. But as also Joe mentioned, these patients, they have problems and they're never going back to normal. But the young ones, we might be able to get more close to normal, more to where they want to go. But we need to do very, very good rehab afterwards. And maybe also before, we don't know yet. But I think that the late rehab is much, much more important than the immediate rehab after surgery. So the jury is still out there. But in my personal opinion, when these patients are not responding sufficiently with exercises, activity modification, hip arthroscopy with labral repair and bony adjustments is a good and relevant option. But we need more and better research. And when you look at the anatomy here, then what is actually happening is that this is a labrum, this is not a meniscus. A lot of you know the shoulder. And the shoulder is just a dysplastic hip joint. We were walking on all 4 once, and this is the same kind of joints. And they have a labrum there as well. But here we have an acetabulum that is really covering a lot. And then I think one of the main reasons we have a labrum, the main functions, is that it gives a suction seal and not so much makes the acetabulum bigger. That's also part of it, but maybe the suction seal is very important. So what's happening is that when you have this cam problem, or you have a pincer, or your combinations, then this labrum, this soft part, gets beat up a lot. And like a piece of copper that gets bent 1,000 times, it doesn't break, but it's just hanging there. And it's painful. There's nociceptors in the insertion. So it's painful, and it's hanging, dangling there, and it sometimes gets impinged there, and it's in direct connection with the cartilage. So when I look into a patient like that, and I push the labrum, I can see that I push the cartilage as well, and we get what we call the wave sign, that you sort of like a big carpet lying there, and then I push the labrum, and it bulges. So this is because the cartilage is beginning to get loose from the bone. And if you saw that in a knee, we would die. Oh, what can we do? It wouldn't be good in any way. But in the hip, somehow we survived it. And this is what's happening. This is not a labral tear. We call it tears, but very rarely we see tears that look like meniscus tears. I would say lesion is a better word. And I think that's one of the reasons they are so difficult to see properly on MRI. This is how it often looks. You have the labrum up here, you have the femoral head, acetabulum here, and you can see that it's a bit loose, and it's an inflammation in the contralabral transition. So, I'm a surgeon, so you have to see some surgical pictures as well. This is the femoral head. This is the acetabulum. Here we have the labrum, and up here the red thing is the capsule. And this is my knife, and I'm doing the capsulotomy. Then I'm going in here on the backside of the labrum, and I'm taking away synovial tissue, and I'm taking down the labrum a little bit to free the edge of the acetabulum. This is the labrum here. This is acetabulum, and I'm using a radiofrequency device here to take away the synovium, so that I can get room to do a debridement of the acetabular rim, put in my anchors, And then I put in my suture under the labrum, and then I pull the labrum up, and then in that way I also pull the carpet up where the labrum, where the cartilage was doing the wave sign. So I pull it up and I put in my stitches, and it looks like this, and then we hopefully will make it heal again, and we will have the suction function back that the labrum is giving. In rare situations, we also have to do labral reconstructions. We use a piece of the iliotibial tract. You can also use a piece of the gracilis tendon. When you have a labrum that is totally destroyed in young patients, and there we measure, and then we put in the graft, and we can reconstruct and get the suction seal restored. The last thing I want to cover is this dysplasia, because we've seen lots of groin patients, and in sports orthopedics, in arthroscopy departments, we didn't see a lot of hip patients because they were either they had osteoarthritis or they didn't. And then if they had osteoarthritis, it was the arthroplasty surgeons and not us. That's the way it is in Scandinavia anyway. But now we see lots of patients with hip problems, or also different kind of hip problems, and we see more and more patients with dysplasia. And we should be very careful, because a patient with dysplasia like this, with a center edge angle of 14, very, very little coverage here, if we do a labral repair here, well, the situation is the same, and it's a she in most cases, will probably get the same situation, the same labral tear again in a few years. So what we need to do here is probably to do what you know here very well in Switzerland, the GANS operation, as it's called over the world, periacetabular osteotomy. It can be done in various ways, but we are taking the acetabulum and making the sealing a bit bigger, putting the head a bit over the head better, so that there's a better bony sealing in the joint. Julie Jacobsen, Danish physiotherapist, who's close to finishing her PhD now on these patients. She looked at 100 patients with hip dysplasia, and she found actually that 56% of them had iliopsoas-related pain. That was pre-operatively. And 42% had abductor problems. It's not adductor, it's abductor problems. And then she did a Hager's on them and found that there was a significant inverse linear association between muscle tendon-related pain and self-reported Hager's. So the more muscle pain, the worse hip score. So maybe some of these patients actually, maybe I'm just being devil's advocate here, didn't need the big periacetabular osteotomy, but actually could do with some good muscle exercises and instructions and maybe modifications of activities, but we don't know. No one ever examined that yet. But I know Julia's got some ambitions there. So we need to be aware of how to strengthen all of these various muscle groups that are important. This is the hip flexor exercise I showed you earlier. This is very simple rubber band adductor strengthening exercise, 13% strength increase in 8 weeks in an RCT. And you know the Copenhagen adduction exercise that Andreas Serner and Les Ishøj and also Joar Harøy have published on in the last years and showed that they have a very good effect on training their adductors. And I'm the adductor nerd, as you can hear. I've been interested in adductors for 30 years. And I'm really happy to hear that now we know that the adductors need it. I told you many years ago. But it's really nice you make the evidence for it now. So, take-home message. We have new terminology and definitions that have been agreed upon, both on the traditional groin problems, but also increasingly on the hip joint problems, and perhaps this weekend we'll have even more. Evidence-based examination techniques, measuring and monitoring tools are available. Get to know them, learn how to do it, and use it. Use it in your everyday work, and use it in your research. Treatment options are increasingly evidence-based. They are a little bit lacking behind, I admit. We need to get going there also for some of the other muscles. Use sufficient exercise stimulation and time. These are long-standing patients, most of them. They have had problems for a long time. They have lots of muscular deficits. They have a lot of coordination deficits that need to be restored. I mean, we take an acute ACL injury, and most of us agree that you shouldn't go back after ACL surgery until a year. Yeah, some of it has to do with the structure of the ACL, but a lot of it has also to do with the disruption total disruption of the way the muscles are working and coordinating. So this is very important. Use the 99 Lancet study. You should take a look at it. It still works, actually, even it's 20 years old. Restore the associated pelvic muscular deficits. It's not only one muscle, it's always something else too. And restore the demands and skills needed to participate in sport, including endurance. Remember the endurance as well. And monitor the groin and hip status with Hager's. That is very helpful. Thank you very much.